Good morning, everyone. I am Dr. Salman Hussein, consultant anesthesiologist and critical care specialist. Uh, Today, our topic is uh, establishment of IV access in a stimulated environment. Indication: fluid and blood replacement, drug administration, obtaining venous blood sample for lab analysis. Types of IV access: peripheral venous access, central venous access, veins located deep in the body like internal jugular vein, subclavian vein, femoral, and peripherally inserted central catheter (PICC) lines. These are the various veins that have to cannulated during the various procedure like external jugular vein, medial cubital vein, cephalic vein. IV administration sets: macro dip set 10 gits 1 ml for giving large amount of fluid. Micro dip 60 GTS is to 1 ml for restricting amount of fluid. Blood tubing has a filter to prevent clots from the blood products from the entering the body. Measured volume delivers specific volumes of fluids. IV extension tubing extends original tubing. Electromechanical pump tubing specific for each pump. Miscellaneous: some sets have a dial that can set the flow rates. Types: over the needle catheter, hollow needle catheter, plastic catheter inserted over the needle. These are the various IV set, IV cannula. Uh, these are the type: over the needle catheter, hollow the needle catheter, and plastic catheter inserted over the needle. IV access: successful completion of any procedure required careful preparation, attention to patient positioning, and prior collection of needed equipment is mandatory. Additionally, predicting difficult access and the use of technique to aid the vasodilation will greatly facilitate successful cannulation. The use of topical anesthesia may be useful in some populations, especially in pediatric population. Patient positioning: for proper IV access, patient positioning is very important, and patient's positioning should be first. The hand should be kept near the when IV cannulation is done. First, immobilization of the hand should be done. Then, hand should be kept at safe position, that no trauma or something don't happen to the hand. Miss in place: prior to beginning the procedure, gather all the required equipment should be done first, because during the difficult IV access, it is very mandatory and it is very required, because during difficult IV cannulation, uh, much bleeding and extravenous tubing, extravenous cannulation may be occurred, so that all the equipment should be gathered first. So this is called miss and place. Predicting difficult access and promoting vasodilation. Difficult access conditions that may predict difficult access include dehydration, chronic illness, venous scarring from the frequent IV access, IV drug use with venous scarring, obesity, significant edema, tortuous fragile vessel due to advanced age, thin vessels wall due to age, steroid use, certain disease condition. Before the IV cannula, before the introduction of the IV cannula, first we should have tourniquets should be placed. After tourniquet, then venous access are prominent. Then introduction also to be easy. Topical anesthesia, mainly pediatric population and also adult population, to prevent the much more pain. Topical EMLA should be given over the skin sample. It's a mixture of the local anesthetic, 2.5% lidocaine and 2.5% pilocaine. Other also local anesthetic also can be used, like LET, lidocaine 4%, epinephrine 1.1%, and tetracaine 0.5%. Explain the procedure. to do every procedure before we should first explain to the patient about the procedure and details explanation, then procedure should be done. Troubleshooting. During IV access, the troubleshooting is the whether it is introduced into the vein or outside the vein or extravenous channel happen. So how to confirm it? First, we have to check whether it is blood is coming or not, and also we can give IV set and fluid introduction can be given so that fluid is if going is properly, then IV cannula done successfully. Inability to advance catheter. There are multiple causes can be happen if we cannot able to advance the catheter, like many venous valve present in that vein, and it may be possible that introduction of the cannula outside the vein. So inability can be happen in and happen in multiple times. It is also possible if patient given multiple times of chemotherapy or radiotherapy, then vessels are so much narrow, so IV introduction much more difficult, and multiple times we are unable to introduce the catheter into the vein. Early complication, arterial placement, air embolism, catheter fracture, and embolism. Arterial placement sometimes happen because some patient there are artery is so much superficial, then we cannot differentiate the vein and artery. So arterial introduction to the cannula is much more common. Air embolism. During the introduction of the IV cannula, there is so much time that air can be passed to the from the saline bottle or IV set, then air embolism can be happen. And if that happen, then immediately the IV set should be should be given the air outside, then IV fluid should be given, and less than 5 ml. If volume is the less than 5 ml, then air cannot be passed to the heart. But if more than 5 ml, then it can definitely cause pulmonary embolism or air embolism to the brain and any other vital organ. Catheter may be fractured, maybe embolism can be done. It happens so much time, multiple time. Catheter is not good in quality, or something wrong introduction to the other than vein may be happen. Late complication. Late complication are local site infection, thrombophlebitis. This is the peripheral venous thrombophlebitis. After the IV cannulation, thrombophlebitis can happen. It is due to local inflammation, local infection. For that reason, thrombophlebitis can be prevented by following this recommendation: utilizing septic technique, using alcohol or iodine prior to insertion, securing catheter appropriately, avoiding lower extremity insertion site, inspecting for thrombophlebitis daily, replacing catheter every 72 hours, avoiding unnecessary tubing, changing, replacing, dressing as needed. Needle stick injury to the healthcare worker and other hospital employees is commonplace. It is estimated over 8 lakh needle stick injuries occur in each year in United States hospital. Appropriate universal precautions should be always maintained to protect the patient, the person performing the procedure, and other individuals involved in all aspects of care. This includes hand washing, the use of gloves and protective barrier, and proper shirts. disposal, and correct the use of the safety features. Central venous catheterization. Objective, indication and contraindication, complication, technique, basic principle, specifies by site, tips and basic material. Indication, central venous pressure monitoring, volume resuscitation, cardiac arrest, lack of peripheral access, infusion of hyperalimentation, infusion of concentrated solution, placement of transvenous pacemaker, cardiac catheterization, pulmonary angiography and hemodialysis. Relative contraindication, bleeding disorder, anticoagulation or thrombolytic therapy, combative patient, distorted local anatomy, cellulitis, burns, severe dermatitis at the site or vasculitis. Complication, vascular, air embolism, arterial puncture, arteriovenous fistula, hematoma, blood clot, infectious, sepsis, cellulitis, osteomyelitis, septic arthritis, miscellaneous, dysarrhythmia, catheter knotting, malposition, nerve injury, pneumothorax, hemothorax, hydrothorax, hemimediastinum, bile or bladder perforation. Technique, Seldinger technique, use introducing needle to the locate vein, where is threaded through the needle, needle is removed, skin and vessels are dilated, catheter is placed over the wire is removed and catheter is secured in the place. This is the proper procedure which are given in the column. First, to locate the vein, then introduction the needle to the vein, then you have to place the guide wire. Over the guide wire, catheter to be placed, and after that, if blood are coming from the channels, then guide wire should be taken out. Basic principle, decide if the line is really necessary, know your anatomy, be familiar with the equipment, obtain optimal patient positioning and cooperation, take your time, use sterile technique, always have a hand on your wire, ask for help, always aspirate as you advance, as you withdraw the needle slowly, always withdraw the needle to the level of the skin before redirecting the angle. Obtain chest X-ray, post-line placement and review it. Location and advantage and disadvantage. First, internal jugular vein. Bleeding can be recognized and controlled. Malposition is rare, less risk of pneumothorax. Disadvantage, risk of carotid artery puncture and pneumothorax possible. Femoral, easy to find vein, no risk of pneumothorax, preferred site for emergency and CPR, fewer bad complication. Disadvantage, highest risk of infection, risk of DVT, not good for ambulatory patient. Subclavian advantage, most comfortable flight for conscious patient. Highest disadvantage, highest risk of pneumothorax, should not be on intubated patient, should not be done if less than 2 years, vein is non-compressible. Subclavian approach. In subclavian approach, the actual site is the below the lateral border of the sternocleidomastoid, below and behind the 2 cm of the lateral border of the sternocleidomastoid, and behind 2 cm below and 2 cm behind. And the introduction of the needle to the opposite shoulder. Then the procedure is the same. First, we have to introduce the needle, locate the vein. Then we have to replace the guide wire. We have to introduce the guide wire, and then catheter to be introduced over the guide wire. Guide wire will be taken out. Then catheter to be placed properly. Internal jugular vein approach. In internal jugular vein approach, the position is the patient position is the mainly carotid medial to the carotid artery, and this is the approach. The internal jugular vein normally placed in lateral to the internal carotid artery. So first, there is a triangle. You should have identified. The triangle is anterior border of the sternocleidomastoid, posterior border of the sternocleidomastoid, and clavicle. Then you have to feel the internal carotid artery pulsation. Then it will have to replace. Then it will have to introduce the needle, and if blood comes, then same the procedure. Femoral approach. Uh, Here is the femoral approach. Femoral vein, femoral vein is placed normally medial to the femoral artery. First vein, then artery, then nerve, vein structure. So femoral vein extreme medially. First you have to palpate, patient will be supine position. First you have to palpate the femoral artery pulsation. Then you have to locate the vein. Then needle introduction should be done. If blood comes, then same procedure will be done. Procedure note, name the procedure, indication for procedure, comment on consent if applicable, describe what you did including preparation, comment on aspiration, flushing of pores, how did patient tolerate the procedure, any complication. Tips. After 3 to 4 tries, let someone else try. Get chest X-ray after unsuccessful attempt. If attempt at one side fails, try new side on same side to avoid the bilateral complication. Hold positive pressure ventilation as the needle penetrates the chest wall in the subclavian approach. If you meet the resistance while inserting the guide wire, withdraw slightly and rotate the wire and re-advance. Align the bevel with the syringe and marking. Use the vein on the same side as the pneumothorax. Withdraw slowly, will often hit the vein on the way out. And then latest approach, ultrasound guided central venous access. First, the ultrasound probe should be kept onto the internal carotid artery and internal jugular vein. And after you can see in the monitor the pulsating internal carotid artery, you can easily identify that it is internal carotid artery, and the lateral to the internal carotid artery there should be internal jugular vein. Then ultrasound guided, you can introduce the needle and same procedure can be done, and it is very much easy than previous approach, as previous approach was blind approach. This is the catheterization key. This is the catheter, 3 channel. This is the guide wire. This is the dilator. This is the syringe, and this is the objective, properties, functions, blood products. Blood is considered as a river of life, fluid of life, and growth and health. Average human has a 5 liter of blood, 8% of the total body weight. It is a transporting fluid. It carries vital substance to all the parts of the body. Properties of blood: color range. Oxygen rich blood is scarlet red, bright crimson. Oxygen poor blood is purple red. Red color comes from the several millions of red cells present in it. pH must remain between 7.35 to 7.45. Temperature 38 degrees C or 100.4 degree Fahrenheit. Blood is properties of blood. Blood is 5 times more viscous than water. Blood is a specialized type of connective tissue in which living blood cells, formed element, are suspended in a non-living fluid matrix called plasma. Cellular part, formed element; non-cellular part, plasma. Total weight of the blood is 8% of the total body weight. It is plasma, which is amount of 55%, and formed element, which is amount of 45%. In plasma, there is protein is 7% and 91% are water, and other solids are 2%. Proteins are albumin mainly 58%, globulin 38%, fibrinogen 4%, and other solids are ion, nutrients, waste product, gases, and regulatory substance. And formed element number of cubic millimeter. platelets 250 to 400,000, white blood cell 5 to 9,000, red blood cells 4.2 to 6.2 million. And white blood cells are neutrophils 60 to 70%, lymphocyte 20 to 25%, monocyte 3% to 8%, eosinophil 2% to 4%, and basophil 0.5 to 1%. Functions of blood. Blood performs a number of functions: distribution, regulation, protection. Distribution function: nutritive, respiratory, excretory, transport. Regulation, regulatory functions: maintenance and buffering. And protective function: preventing blood loss. And defensive function. This is the same slide that discussed previously. In blood is formed by 55% of plasma, 45% of cellular elements. In 55% of plasma, the major functions are solvent for carrying other substance. The salts in the plasma are sodium, potassium, calcium, magnesium, chloride, bicarbonate, osmotic balance, pH. These are helps to osmotic balance, pH buffering, regulation of membrane permeability. Plasma protein, that are albumin, fibrinogen, immunoglobulin, that causes osmotic balance, pH buffering, and clotting and immunity. Substances transported by blood, nutrient like glucose, fatty acid, vitamin, waste product of metabolism of respiratory gases like O2, CO2, hormones. Cellular element, 45%. Cell type, number and function: erythrocyte 5 to 6 million, transport oxygen and length, transport of carbon dioxide. Leukocyte 5,000 to 10,000, defense and immunity mainly functions. And platelet 250 lakh to 4 lakh, mainly functional blood clotting. Blood products, components of the blood which are collected from a donor for use in blood transfusion. Blood products are blood, the cellular component, plasma derivative. Cellular component: red cell concentrate, platelet concentrate, granulocyte concentrate. Plasma component: fresh frozen plasma, cryoprecipitated, cryopoor plasma, stored plasma. And plasma derivative: albumin, immunoglobulin, coagulation factors. Blood component: first whole blood, then first slow centrifugation should be done, then it divided by packed red cell and platelet is plasma. Then high speed centrifugation to be done, then it divided by 1 unit of random donor platelets, 1 unit of fresh frozen plasma. Thawing precipitate the plasma protein, then cryoprecipitate to be obtained. Whole blood is equal to donor blood plus with anticoagulant. 1 unit is 450 ml. Anticoagulant rich coagulation factor, hematocrit 45%, stored at 2 to 6 degrees centigrade, shelf life 35 days. Indication to be given a whole blood: acute blood loss with hypovolemia, exchange transfusion, severe anemia at birth, severe hyperbilirubinemia, massive transfusion, cardiopulmonary bypass surgery. Fresh whole blood, then light spin 22 degrees centigrade within 8 hours, and it divided by packed red cell, platelet rich plasma. Then heavy spinning 22 degrees centigrade, it divided by platelet concentrate and fresh plasma. Platelet concentrate stored at 22 degrees centigrade and fresh plasma to be freeze. Red cell concentrate, also called packed red cell, platelet and plasma are removed. 1 unit 330 ml, hematocrit 65 to 75%, and shelf life 35 days, and stored at 2 to 4 degrees centigrade. Indication of red cell concentrate: anemia, thalassemia, and sickle cell disease. Fresh frozen plasma, removed fresh blood and rapidly frozen. 1 unit 2 to 250 ml, contains all coagulant factors, stored at -40 to -50 degrees centigrade, and Shelf life is 2 years. Indication of fresh frozen plasma, single clotting factor deficiency, multiple clotting factor deficiency, DIC, massive transfusion, warfarin overdose, hemorrhagic disease of neonates, and TTP, thrombotic thrombocytopenic purpurea. Fresh frozen plasma then thaw at 4 degrees C and heavy spin. It divided with cryoprecipitate and cryo-removed plasma. Cryoprecipitate should be refrozen within 1 hour, stored at minus 18 degrees centigrade, and cryo-removed plasma freeze minus 80 degrees centigrade immediately, stored at minus less than equal to minus 18 degrees centigrade. Cryoprecipitate, the indication of the to give cryoprecipitate are fresh frozen plasma at 4 degrees centigrade, rich in factor 8 and fibrinogen, 1 in 15 to 20 ml, stored at minus 30 degrees centigrade. Shelf life is 2 years. Indication of the to give cryoprecipitate is hemophilia A, von Willebrand disease, factor 8 or fibrinogen deficiency. Platelet concentrate. Platelet rich plasma concentrate stored at minus 20 to 24 degrees centigrade. Shelf life 5 days, 1 unit 15 to 20 ml. Uses thrombocytopenia, drug induced AGE. Prothrombin complex concentrate PCC derived from pooled plasma contain 2,7,9,10 coagulation factor. Emergency reversal of warfarin therapy, as warfarin norfarin prevent the clotting of 2,7,9,10. So prothrombin concentrate very useful in emergency reversal of warfarin therapy. Autologous blood collection, infusion of client's own blood can be collected weekly as long as client every week certain amount of blood to be collected, and it can be freeze, and during the emergency situation that blood can be given. This is the concept of autologous blood transfusion. Up to 3 weeks before surgery it should be done, and hematocrit are 45%, stored at 2 to 6 degrees centigrade, shelf life 35 days. Today last topic is perioperative fluid therapy. Total body water, approx 60% of body weight, varies with age, gender and body habits. 50% of body weight in female, 80% of body weight in infant. Less in obese, fat content, little water. Body water compartments, intercellular volume 2/3 of total body weight, extracellular volume 1/3 of total body weight. Intravascular plasma volume of 1/4, extravascular interstitial fluid and others 3/4. Preoperative evaluation of fluid status. First, mental status, history of intake and output, blood pressure, supine and standing, heart rate, skin turgor, urine output and CVP. Orthostatic hypotension, systolic blood pressure decrease or greater than 20 mmHg from supine to standing, indicate fluid deficit of 6 to 8% of body weight. Heart rate should be increased as compensatory measure. If no increase of heart rate, may indicate autonomic dysfunction and antihypertensive drug therapy. Basics: osmoles, osmolarity, plasma osmolarity, tonicity. Osmoles, unit of concentrated osmolarity, active particles. Osmolality, osmotic active solutes per volume of solution, milliosmol per liter. Osmolarity, milliosmol per kg. Plasma osmolarity, 290 milliosmol per kg. Tonicity, relative osmotic activity, isotonic or hypotonic or hypertonic. Intravenous fluid therapy. Intravenous fluid therapy may consist of infusion of crystalloid, colloids, or a combination of both. Indication: volume resuscitation, vehicles for IV drug. Types: crystalloid and colloid. Crystalloids, clear fluid made up of water electrolyte solution, will cross a semi-permeable membrane. Grouped as isotonic, hypertonic and hypotonic. Example, normal saline 0.9%, 3%, dextrose solution 5%, 10%, 20%, 25%, DNS, dextrose normal saline, ringal lactate, isolate P. Crystalloid 0.9% normal saline contain sodium 154 milliosmol per liter, chloride 154 milliosmol per liter, osmolarity 308 milliosmol per liter, pH 6, isosmolar compared to the normal plasma. Indication, intravascular resuscitation and replacement of salt loss like diarrhea, vomiting. Also for diluting packed RBCs prior to transfusion, used for diluting the drugs. Distribution stays almost entirely into the extracellular phase of 1 liter to 750 ml extravascular fluid and 250 ml of intravascular fluid. Within 1 liter, mainly 750, only 750 ml, only 250 ml intravascular fluid and 750 ml are in extravascular fluid. So, in normal saline, if given on normal saline to a patient, it mainly goes on to the extravascular fluid, less in intravascular fluid. It is very important during hypovolemic shock, because during hypovolemic shock, if normal saline given, mostly it went off to the outside the vessels. So mainly edema mainly happens. No intravascular fluid present in the body, so blood pressure not raised so much. So if any hypovolemic shock occurs during intrasurgical period or post-surgical period, only blood can be given to improve the blood pressure. Complication, when given in large volume, can produces hyperchloremic metabolic acidosis because of high sodium and chloride content. Hyperchloremic metabolic acidosis is one of the most dangerous complication of normal if given excess normal saline. If we given in critically ill patient, it causes so much problem to the patient. 0.5% normal saline, half of normal saline, hypotonic saline, sodium 77, chloride 77, osmolarity 154 milliosmol per liter, indication fluid therapy for pediatric patient, maintenance fluid therapy, complication leads to hyponatremia if plasma sodium is normal, may cause rapid reduction of serum sodium if used excess or infused too rapidly. This may lead to cerebral edema and rarely central pontine demyelinations. Use with this caution. 3% saline, hypertonic saline, 3% contain 513 milliosmol per liter of sodium and chloride for each. Osmolarity 1026 milliosmol per liter, pH is 5. Indication, treatment of severe symptomatic hyponatremia, coma like seizure, to resuscitate the hypovolemic shock. Leads to an osmotic gradient between ECF and ICF, causing passage of fluid into the extra compartment space. Must be administered solely and preferably with CV line or central venous line. It carries risk of causing phlebitis, necrosis or hemolysis. Complication, precaution in patient with congestive heart failure, as severe renal insufficiency, edema or sodium retention. Dextrose 5% is already at D5W, 50 gram per liter of glucose, 252 milliosmol per liter, pH 4.5, regarded as electrolyte free, contain no sodium, potassium chloride or calcium. Indication, primarily used to maintain the water balance in patients who are not able to take anything by mouth. Commonly used postoperatively in conjunction with salt retaining fluid like saline. Hypernatremia treatment. When infused is rapidly redistributed into the intercellular space, less than 10% stays in the intravascular space, therefore it is of limited use in fluid resuscitation. Side effect, iatrogenic hyponatremia in surgical patient, hyperglycemia not compatible with blood as it causes hemolysis. Concentration of various type of dextrose, 5%, 10%, 20%, 25% and plasma, 5% 252 osmolarity, 10% 505, 20% 110, 25% 1262 and plasma 290 osmolarity. Ringal lactate, most physiological solution, electrolyte composition similar to the ECM. 1 liter of lactated ringer solution contains sodium ion 130 millismol per liter, chloride ion 109 millismol per liter, lactate 28 millismol per liter, potassium 4 millismol per liter, calcium ion 1.5 millismol per liter, osmolarity of 273, pH of 6.5. Lactate is converted to bicarbonate in the liver. Indication: deficit or intraoperative fluid loss, severe hypovolemia. Precautions: severe metabolic acidosis can be happen. If impaired lactate conversion is occurred. Don't give with the fluid as calcium binds with citrate, reduce anticoagulant property. DNS: 0.9% saline and 5% dextrose. Sodium 154, chloride 154, 5 gram of glucose, osmolarity 432 millismol per liter. Maintenance solution: correction of fluid deficit with supply of energy compatible with blood. Isolate P: multiple electrolytes and dextrose solution, sodium 26, potassium 20, magnesium 0.3, chloride 21, acetate 23, pH 0.3, isotonic. Indication: mainly given in pediatric surgical patients. Colloids: the colloid solution contain particles which do not readily cross the semi-permeable membrane, such as the capillary. Thus, the volume infused stays initially almost entirely within the intravascular space, stays intravascular for prolonged period compared to the crystalloid. However, they leak out intravascular space when the capillary permeability significantly changes. Example: severe trauma or sepsis. Because of their gelatinous property, they cause platelet dysfunction, interferes with the fibrinolysis and coagulation factor. Factor 8. Thus, they can cause significant coagulopathy if given large volume. Natural albumin, artificial gelatin, dextran, hestra. Albumin: principle of natural colloid comprising 50-60% of all plasma protein, synthesized only in liver and has a half-life of approximate 20 days. 5% solution is also oncotic and leads to 80% initial volume expansion, and 25% solution leads to 200 to 400% increase in volume. Used for emergency treatment of shock, especially due to loss of plasma, acute management of burns, fluid resuscitation in ICU, hypoalbuminemia. Side effect: pruritus, anaphylactic reaction, coagulation abnormality as compared to the synthetic colloids. And disadvantage: cost effectiveness, volume overload in specific septic shock patient, albumin add to interstitial edema. Dextran: highly branched polysaccharide molecules produced by synthesis using bacterial enzyme and dextran. Sucrose from the bacterial leucocytic mesenteroids. Most widely used are 6% and 8% solution. Excreted by kidney primarily, both lead to higher volume expansion as compared to the haste charge and 5% albumin. Used mainly to improve microcirculatory flow in microsurgical reimplantation, also used in extracorporeal circulation during the cardiopulmonary bypass. Side effect: anaphylactic reaction, coagulation abnormality, interference with cross-match, PPT, and acute renal failure. Gelatins: large molecular weight proteins formed from hydrolysis of collagen, produced by thermal degradation of cattle bone gelatin. 3 types of gelatin solution currently in use are succinylate modified fluid gelatin, jellyfusion, plasma gel, urea cross-linked gelatin, example gelatin, oxypolygelatin, gel fundol is not available normally. These two above two are mainly available in every site, but third is very difficult to get access. Gelatin leads to 78% volume expansion, indication rapid expansion of intravascular volume and correction of hypotension. Advantage: cost effectiveness, no effect of renal impairment, does not affect coagulation. Disadvantage: hypersensitivity and anaphylactic reaction. Hydroxyethyl starch derivatives of amylopectin, which is highly branched compound of starch. 6% haze solution are isotonic, 10% solution are hyperoncotic, with a volume effect of exceeding the infused volume about 145%. Duration of volume expansion is usually 8 to 12 hours. Advantage: cost effectiveness, cheaper, comparable to volume expansion of to albumin. Disadvantage: associated with first and second generation haze, coagulation abnormality, accumulation, anaphylactic reaction, renal impairment, increase in amylase level. Tetrastarch, third generation haze starch, newer starch based on plasma expander, improved safety and pharmacology property, minimal effect on coagulation process and platelet function, less accumulation and tissue storage, no effective effects on renal function, and positive effect on tissue oxygenation and microcirculation. Colloid or crystalloid resuscitation. Recommendation: colloids should not be used as the sole fluid replacement in resuscitation. Volume increase should be limited because on side effect and lack of evidence for their continued use in the acutely ill patient. In severely ill patient, principally use crystalloid and blood product. Colloid may be used in limited volume to reduce the volume of fluid and required or until blood products are available. In electrosurgical patient, replace fluid loss with physiological Ringer solution. Blood products and colloids may be needed to replace the intravascular volume acutely. Perioperative fluid requirement: the following factor must be taken into account: CVE, maintenance fluid, deficit, third space loss, and replacement of loss. Compensatory intravascular volume expansion. Most general and regional anesthetic cause arteriolar and venous dilation. Most general and regional anesthetic drugs that causes arterial and venous dilation. So expanding the vascular capacity, which reduces the peripheral venous pressure and venous and cardiac output. Fluid must be administered to expand the blood volume to compensate for venodilation. Expansion with 5 to 7 ml per kg body surface must occur before to simultaneous with the onset of anesthesia. Maintenance fluid requirement: 4:2:1 rule. 4 ml per kg per hour for the first 10 kg of body weight, 2 ml per kg per hour next 10 kg of body weight, and 1 ml per kg subsequent kg of body weight. Example: 70 kg patient, maintenance fluid is 4:10 is 40, 2:10 is 20, and 1:50. So 110 ml per hour. Deficit: number of hours NPO into maintenance fluid requirement. Measured fluid losses: example, NG suctioning, vomiting, stoma outflow. 70 kg patient fasting for 8 hours, then deficit will be 8 into 110, 880 ml. Then half in first hour fluid to be given, 1/4 then next 2 hours. Third space losses: isolating transfer of ECF from functional body fluid compartment to non-functional compartment depends on the location, duration and surgical procedure and amount of tissue, trauma and ambient temperature, room and ventilation. Replacing third space losses: minimal surgical trauma 0 to 2 ml per kg per hour, like herniorrhaphy. Moderate surgical trauma 2 to 4 ml per kg per hour, like cholecystectomy. Severe surgical trauma 4 to 6 ml per kg per hour, major bowel resection. Blood loss: replace 4 cc of crystalloid solution per cc of blood loss. Crystalloid solution leave the intravascular phase. As crystalloid solution very rapidly leave the intravascular space, so crystalloid solution much more needed than 1 cc of blood. When using blood product or colloids, replacement blood loss volume per volume. Fluid management in a starting with a hemoglobin level 50 gram per dl for a 70 kg patient undergoing gastrectomy who has been fasting for 8 hours. First hour should be 350 ml central venous half of deficit, then 880 by 2, 440, maintenance 110, loss 50, and third space loss is 4 to 5 ml per kg per hour, then 420. Second hour, half 1/4 of the 180, 220, 110, 250 is the loss, 420 is the third space loss. And third hour, that will be 220 for the maintenance or fluid deficit, 110 for maintenance, 250 for fluid loss, and third space loss is the 420. Like that only. And fourth hour, like that only. Summary: most physiological solution is ring lactate, rich in sodium is NS and DS, rich in potassium isolate P, glucose free RL NS 3% saline, sodium free dextrose, potassium free NS, DNS and dextrose. Can correct the acidosis directly, right? RL isolate P. Thank you.